They say that it affects 1 in 10, which is a good example, because my mother had 10 children, and coincidentally one of my sisters ended up with schizophrenia.
It takes over their life really. They sort of lose their identity and they become a schizophrenic person rather than a person with schizophrenia, and they sort of tend to lose themselves and their identity. I think that's really difficult because it seems to consume every part of their waking day.
I think there's no particular reason why certain people develop schizophrenia. We do know it runs in families, but in general terms I would say you cannot blame a person for developing schizophrenia.
Sometimes I can go weeks and weeks without hearing the voices or getting schizophrenic feelings. But other times, I could have it, come and go all the time,
Well, I have had this condition I've got since about 1989, I think, around about then. I find if I get away from people, it's a bit more tolerable then. I did get sectioned, but I ran off. Just so many rubbish from passers-by, I just sort of have to deal with it. Then I eventually went back voluntarily to hospital.
Obviously it's very hard for me to put myself in the position of somebody who has a diagnosis of schizophrenia, but from what I've seen and from feedback and conversations you have with people, and you get to know them over sort of many years, sometimes with people with sort of very enduring illnesses. I've worked with some people for up to 7 years now.
Put yourself wasted space. You'll be sick. It'll kill you. Just be ashamed, look at you. Worthless.
Our trust strives to offer a comprehensive care package to service users who suffer from schizophrenia, but a lot of the patients who have chronic schizophrenia with a lot of residual symptoms have what I would regard as a life that is limited in terms of what they can make of it.
I think a lot of people we see they withdraw themselves a lot from society because that makes it easier for them to deal with the symptoms. There's such a wide spectrum. I think you can think of cases where it's awful and people can't cope with it, and of ultimately taking their own lives, and that's awful. That's the worst case scenario. The other end of the spectrum, I guess, is people who function to a really high level with it and go on to live their lives.
Looking at my sort of worst case scenario is somebody who is very chronic, has lots of symptoms, and has very, very little insight into their illness. So it's really hard to treat because they're not acknowledging that there's a problem, that there's not anything wrong with them.
I have had it diagnosed as schizophrenia, but whether I actually am schizophrenic, I don't know. I just get a real load of trouble from passers-by mostly, and I find it difficult to get. It's hard to get through the day sort of without getting a certain amount of verbal abuse, or whatever you call it.
It's a bit distressing when you're on a bus and you hear a voice and there's coloured people sitting on the bus. And I hear these racial voices, and it upsets me. And because I'm sort of slightly schizophrenic, I imagine things. Put it that way.
Well, the mildest forms of schizophrenia are indistinguishable from people in the community, so they can hold down a job and you wouldn't know that they have schizophrenia unless they told you, and the more severe cases would probably be institutionalized.
I guess in the most severe case, you're looking at someone who's completely disassociated with life. I mean, I guess thinking to someone in like an acute hospital environment, somebody is probably hallucinating, you know, visual hallucinations, auditory hallucinations, tactile hallucinations as well quite often. Seen people very, very distressed. I mean, it certainly is a debilitating condition, and I guess the problem with it is that maybe it's only people with first-hand knowledge of it, or people that work with it, that maybe understand how debilitating it is. You know, other illnesses, it's often quite obvious that people suffer from an illness because you can kind of quantify it.
I think if you're given a diagnosis of schizophrenia, it's probably more detrimental than being given a diagnosis of depression, because society is more accepting of people being depressed, and I think schizophrenia is still quite an unknown quantity to many people. You often hear people talking about multiple personalities when talking about schizophrenia, so I don't think that the wider public have a real idea of what schizophrenia is, what it's like for people suffering, and I think because of the ignorance around the illness, that's why there is still a stigma, and I think sometimes it's hard to move away from that.
I think it's come a long way, the stigma of actually being diagnosed and labelled with the condition of schizophrenia. I think people's perspective now is that, you know, they tend to accept that people have got illnesses, mental illness.
Part of the sort of stigma that goes alongside mental illness, it's often quite hidden, and people will withdraw, you know, and the symptoms are kind of internalised. Makes it very difficult for other people to see, whereas somebody with, you know, diabetes, you can do a blood test for. Someone with a you know, broken leg or an injury, it's often quite evident.
It's more talked about now than it was many years ago, and I think, you know, 34 years in the profession, I've seen that, you know, really come to light. 20-30 years ago, it was seen and not heard. You didn't even talk about it.
I think there's much more of an emphasis now on community treatment, whereas before you were obviously talking about the older institutions, and maybe people were kind of kept separate almost from society, whereas now, you know, through the recovery process and through, you know, sort of normalisation and that the people are being encouraged to integrate much more with society.
I think people with schizophrenia, when they are well controlled on antipsychotic medication, mainly antipsychotic medication, they can live a life that is similar to people who do not have this diagnosis.
Well, at the beginning it was rough and at the start of my mental illness, but as it carried on, I realised that the medication they gave me made me better, so I stopped hearing voices and start looking after my own caring now.
Today, thank God, there are support networks out in the community, such as Mind. You know, there's various networks now, social events where people go on walking clubs, and they actually meet and talk and are treated as normal individuals, which I feel, you know, they should be.
Oh, I get the help from Mind, go to walks. Hightown a little bit, take me and sort things out for me. And I get a little help from Slippers Hill and the mental health support team.
Once I get going, but I need motivation and, you know, a little bit of care. My motivation's good, but you know, I still need a little bit of help. I was in St Julian's for a year, and everyone helped, everyone got along with each other. No differences or anything.
Well, I'm only quite a quiet person, so most of the time I stay in, apart from when I work, like I do voluntary work.
I spent 3 years trying to do various jobs, but my symptoms got worse, so in the end I had to chuck it in, go to the hospital.
Go on, do it.
Most of my experiences with people who suffer from schizophrenia are positive. I find most of them really pleasant, gentle. They are keen to get help, and they are most of the time willing to engage with the services.
Well, definitely, you know, the media will say, you know, hearing voices, schizophrenic, you're violent. I have very, very rarely come across anybody who is a violent person with schizophrenia. I'd say it's almost the other way. Most of the people I know who have schizophrenia tend to be more vulnerable, quite passive, and actually they'd be more at risk of somebody else hurting them or taking advantage than they would ever be of hurting or taking advantage of somebody else.
People that are actually relapsing and quite unwell with the illness do respond to auditory and visual hallucinations, where the voices actually say, look, you know, this guy's going to kill you, or is going to do this, that and the other to you. And hence that's why they, for no reason at all, they end up punching or hitting out at somebody that they feel is going to harm them.
Yeah, no, I was scared that voices telling me that they were going to kill me and that. So I was a bit paranoid, what we call paranoid schizophrenia.
The ones that are difficult to engage with our services have little insight and usually are looked after by what we call the assertive outreach team. And I know a couple of patients who used to be under me and now under that team that could be challenging, mainly because of the severity of their symptoms.
Frequently come across people with schizophrenia who suffer from episodes of depression or even elevated mood.
I've got people in between who become quite distressed by the voices, feel quite vulnerable, probably are actually vulnerable to exploitation because of the way they feel about themselves. Quite a lot of low self-esteem with people who sort of have schizophrenia a lot of the time.
This has to do with educating the general public in terms of what schizophrenia is about, and that it is not the case that people with schizophrenia are violent or aggressive, and that is a common misunderstanding in the general public. And unfortunately, when there is a high-profile case, then sometimes this is reinforced.
Well, I think I'd get prejudice whatever I did, so it doesn't really make much difference. I wonder if I always was a slightly borderline case, and then you know, it's a very fractional thing with me. It's very sort of, you know, you could go down the toilet any time, but that's, you know, nothing I can do about that.
There is bipolar depression have also an effect on people's diagnosis of schizophrenia.
Not unusual to have what we call an affective component. That will mean a mood disorder like depression or anxiety to go alongside with a main diagnosis of schizophrenia?
A lot of people, I'd say, suffer from the sort of the negative symptoms of schizophrenia and sort of quite withdrawn at times. But I also have experienced clients who have mood swings and mood variations and do go quite high.
I always find there's normally a mood component to it, which I know formally they diagnose that as schizoaffective disorder, but I think that's only if there's kind of equal amounts of variation to the mood as there are sort of psychotic symptomology.
It varies. I mean, when people are obviously relapsing or, you know, not concordant to medication or whatever, their mental health sort of deteriorates rapidly, depending on the degree of schizophrenia.
You know, feeling that they were being violated, maybe touched inappropriately, they were people out to get them, they needed to kind of escape for their own safety, and people have been really confined to either a kind of a safe room, a 136 suite that was kind of padded for their own protection, or they were nursed on maybe 2 or 3 to 1 observations. That would be 2 or 3 members of nursing staff were you know, surrounding the individual really, just to kind of try and maintain their safety and make sure they didn't do any harm to themselves or anybody else. I think more often than not it is a lifetime illness, and the medications will help, you know, alleviate the symptoms and hopefully improve the client's quality of life as much as possible.
In broad terms, you could say that in the past we only had available what we would call the conventional antipsychotics like chlorpromazine and haloperidol. Nowadays we have a quite wide range of what we call the novel antipsychotics available, the atypicals with lesser side effects and a good effective profile.
There's been a huge change or developments in medications used for schizophrenia. I guess you've got the kind of older conventional antipsychotics versus the newer generation antipsychotics.
Well, I was on stelazine at first and that didn't work. Then I went on to sulpiride and that's a bit better. I intend to take that with mecloseril, an epilim anti-fit drug.
I don't know. Mainly clozaril. Over the last, I don't know, 10-15 years it's been clozaril. Or maybe a bit less than that. I was on other medication. I was on the depots, like injections, other tablets. You know, mainly I've been on clozaril though. You know.
There are various schizophrenic drugs that are available to service users, such as Dapixol, Clopixol is another drug that's used.
Olanzapine or risperidone, quetiapine, or the most novel one, aripiprazole.
There's also clozapine, which is very, very effective, and I would say out of all the drugs, clozapine and Dapixol are widely used.
The medication I'm on is the clozaril. Seems to have worked with me so far, you know.
Olanzapine and the clozapine. I've only been on olanzapine and clozapine.
I think the one that we've seen most success, particularly here, is with clozapine, an oral medication, which, you know, is a very sort of intense medication. Needs monitoring very closely through blood tests in clinic once every 4 weeks, This differs to the traditional injection route which a lot of other people are on for schizophrenia due to sort of issues around concordance with medication. But a lot of people have done really, really well with clozapine.
I had, to make it simple, I've had this medication for 3 years and it's worked wonders.
As the voices have stopped, I've just found that where I've had the mental illness and talking back to the voice on the head, I end up talking to myself.
We tend to find the newer generation antipsychotics better at controlling the positive symptoms, and some of them actually will work on the negative symptoms as well. You know, we do have plenty of experience of clients who don't respond to the more modern, the atypical antipsychotics, and they only really respond to the more conventional, older antipsychotics. So it's sometimes it can be almost a case of trial and error with people, although you'll obviously look back at their medication history and try and find at what time in their life the symptoms have been best controlled, and you kind of would then associate that with what types of medication are best for them.
I don't think that there's a particular trigger, apart from the fact that I have noticed that young people who dabble in skunk, so the strong variant of cannabis, for a prolonged period, can be more vulnerable to developing a first episode of schizophrenia.
I was in Hill End. I went into Hill End voluntary. I guess while I was in there, I went in there voluntary because I used to take drugs and certain things happened to me while I was in hospital, and I didn't want it to happen to somebody else, you know.
I guess, you know, drug and alcohol abuse, particularly drug abuse, illicit substances, that you know, there's a well-known link between that and psychosis, and I think that's becoming more prevalent now as drug use becomes more of a problem, and certainly certain types of drugs become more problematic.
We do see lots of younger gentlemen especially coming in as first-time episodes that possibly could end up with a diagnosis of schizophrenia due to sort of use of drugs such as cannabis, sort of coming to see us with first-time psychosis. It doesn't always lead to a diagnosis of schizophrenia, but that's quite common.
A case that I'm working with at the moment where, you know, the client abuses drugs, illicit drugs such as cannabis, cocaine. He knows he's got a diagnosis of schizophrenia, and yet he still abuses the drugs to an extent where the medication has no effect at all. On 2 occasions he's been sectioned under the Mental Health Act. Has a period of 3 to 4 months in hospital. Recovers quite quickly, but it's like a revolving door situation. 9 times out of 10 you'll end up re-offending, using drugs again, and his illness reoccurs again, you know. But that's just one client. Then you get other clients that come to the Clozaril clinic that are concordant to their medication. They stay well and have been well for many, many years.
I'm thinking of a particular person who became quite unwell, no insight, really was vulnerable, and also had children that we needed to be sort of cautious about. And it was quite traumatic in the fact she ended up being sectioned outside of her house. I find that very difficult and distressing, because I don't want, you know, you don't want her neighbours knowing how difficult things are for her, and I really find it hard when police are involved as well, and people are detained against the will, because it's not something you want to, that's not a scenario you want to create with people you've worked sort of well with.
I remember a guy who was really persecuted by delusions. He was also hearing, there was ideas of reference, so he was receiving maybe messages from noises like external stimuli, like cars travelling past. He thought that exhaust pipes were making noises specific to him, and he was terrified that this gang of people were coming to do away with him, coming to kill him. He took himself off to A&E in the end, and we were called down there to assess him, and he was just so distressed, this poor lad, and we were trying to kind of keep him where he was and contain him, but he was so scared they might find him, and he was kind of looking all around him and hyper alert, and feeling that his end had come really, someone was going to get him.
Sorry, You're sick. Yourself. Waste of space, waste of air. Come on.
I wouldn't say the condition's curable. I think the condition can be stabilised, and it again depends on the individual.
I'm not sure if it's curable, but I've definitely seen people in remission. So like most illnesses, it can be managed effectively to the point of a person being symptom-free for many, many years.
I don't know if it's curable. I mean, I think it's curable in the sense of medication completely curing it. Medication will control symptoms, but I think there are people that will have an episode of psychosis, and they'll make a full recovery from it and go on to, for a number of years or maybe even indefinitely without having a kind of second episode.
I think research has shown that in a third of the cases, the available antipsychotic medication does not have the desired effect, as in lifting the psychotic symptoms. But with the medication available and all the other support mechanisms in place, I think that we can offer a good package of care to people who suffer from schizophrenia.
If I'm going to talk to them about my voices, they talk to me, and I have a meeting every 6 months.
I've seen people make, virtually total recoveries from what's been diagnosed as a schizophrenic illness, and they've gone on to kind of go back to work and have personal, intimate relationships, close family relationships. So the spectrum is total, really.
Some people actually accept the fact that they've been labelled and diagnosed with this illness. Others find it very difficult and in denial that they've got this illness. And to be fair, there are people with a diagnosis of schizophrenia that live totally independent in the community without any medication or treatment at all.
And one of the things that always fascinates me is that I've asked quite a few clients before who've got quite chronic mental health problems, in particular hearing voices. I'm sort of saying to them, if you had a switch and you could turn off the voices permanently, you had to make that decision now to turn it off or leave it on, what would you do? And A lot of people have said to me they'd leave it on. The voice has been such a big part of their life, and there's such good companionship, and their life revolves around them now, that if they were to suddenly stop, it would be a huge loss for them. So I've always found that quite fascinating as well.
Oh, you want to call someone, do you? Oh, a little thing. Go on then, pick up the phone, dial the little numbers. No one's going to help you. No one's going to help you. No one wants to help you. No one likes you. No one likes you. We don't even like it. Oh, no answer. Oh dear, what are we gonna do? No one cares. Why would they care? Why should they care? For God's sake.
Hello there, can I have the number please for the mental health hotline? Put me through please.
Good evening, this is the Mental Health Helpline. How can I help you today?
We'd always say if your first sort of symptoms, see GP, because that's normally the person you've seen most, who knows you better than anybody else.
The GP is always the first port of call, because the GP is the person who is best equipped nowadays to identify the first symptoms.
The GP would then refer them to a single point of access, and then from there they would come to the community mental health teams.
You know, quite often when you see an objective professional, although a GP isn't specialised necessarily in mental health training, they've still got a good awareness of symptoms, and they know the thresholds as to when they should be saying, you know, we can't deal with this, we need to refer it on to specialist mental health services.
The way our team works now is that the next port of call would be a referral to the single point of access team, who would carry out a triage of your symptoms and severity and your need, and would look at booking you in for an appointment with the CMHT to do a full assessment of your symptoms.
And they would be assessed by either a social worker, community psychiatric nurse, and then the process then is taken into a multidisciplinary team where it's discussed with the consultant. The consultant then will make a decision.
You know, if there was an emergency manifestation and somebody was really worried, then of course, you know, you'd be accessing, you know, A&E or emergency services if necessary. But again, that's one of the things that we do say is the earlier you can get it treated or diagnosed and treated, the better the prognosis and the treatment outcomes are. So if anyone's worried, then speak to a professional, you know, and you know, explore what is going on and get treatment as early as possible.
The film that you've been watching has talked today a lot about the medical and clinical model in treating schizophrenia. One of the symptoms of schizophrenia, or one of the accepted norms of schizophrenia, can be auditory hallucinations, otherwise known as hearing voices. And I'd just like to give you a tiny bit of information today about the Hearing Voices Network, which is a group that was started in the UK in 1988. It began as a small planning group originating in Manchester and was inspired by the pioneering work of Professor Marius Rom, a psychiatrist from Maastricht in the Netherlands, and the Dutch self-help group Foundation Resonance, which was established through this work. The meetings were very well attended by voice hearers, their relatives and interested professionals, and they have a regular conference in Maastricht. The reason I became quite interested was about 15 years ago. I was working with some voice hearers who talked to me about their voices and said that they felt ashamed to talk about the voices and tell other people. And when they actually did talk to other people about their voices, they felt better. I think the traditional view has always been to deny the voices as part of illness, as not really existing, but that's like denying someone's experience is kind of like denying them as well. So Hearing Voices Network encourages people to talk about their voices, to share coping strategies and ways of dealing with voices, and to not feel ashamed about them. Some people celebrate their voices, some people find their voices a comfort. A lot of people find their voices very distressing. Some people choose to stay on medication. Some people choose to have a break. I'm not going to make any judgment about that today. I'm just here to tell you about the Hearing Voices Network, which is a user-led self-help support group. And I'm sure that the contact number will be put up at the end of this film.
What is the hardest part of living with schizophrenia?
Getting people to understand.